Start, right?
Yes, sir.
So this is going to be a rapid revision, and also I'm going to include all the previously asked ENT MCQs for you, so that you will not waste your time solving ENT MCQs separately. So I'm going to give you high yield points only, so not a proper full-time reading like that. So we're going to cover as much topic as possible. So we're going to start with the ear, then proceed to nose, then finally throat. So first we'll start with anatomy and embryology of the ear. Okay. So first one, see here, pinna develops from hillocks of his. Okay, which develops from first and second arch mesenchyme. All right. So see, this is the first important table that you need to understand. This PDF I will share with you. Don't worry. So just listen to me. Some of the important points you grasp in the class itself. So pinna develops from hillocks of his. External record develops from first pharyngeal arch cleft. Middle ear cleft and east side develops from first endodermal outpoaching. Tympanic membrane from all three layers. The malleus mucus develops from first pharyngeal arch mesenchyme. Stapes develops from second pharyngeal arch mesenchyme. Just look into this. Till the stapes, almost all the structures of external and middle ear develops from pharyngeal arches. So there was a story that pharyngeal arches was not there at the beginning. So fishes had pharyngeal arches developing for mandible and hyoid formation. But as evolution goes, external and middle ear was latest addition to the evolution. So you could see fishes or many of the animals don't have ears, but humans are very advanced. They evolved these first and second pharyngeal structures, ear, external ear, and middle ear from the pharyngeal arches. So why I am saying this? Because the external and middle ear has a separate embryology, while the inner ear has a separate embryology. That's a major thing. So now you come to this inner ear embryology. This inner ear embryology, you just look into this. This otic capsule and otic vesicle are all part of neural ectoderm. All right. So this neural ectoderm forms two main structures, otic capsule and otic vesicle. So these two will be forming the, see, this bony labyrinth formed from otic capsule, membranous labyrinth formed from otic vesicle. Kindly remember this point. This point is very important. This is useful for a lot of understanding of the diseases such as otosclerosis and a lot of understanding about the inner anatomy. So out of all these, which is very important, this one is very important. Tympanic membrane develops from all three layers. Kindly don't forget that. This malleus, incus, this tensor tympani muscle, which is a muscle of malleus, the stapedius, which is a muscle of stapes, all these develop from mesenchyme. That's all. You should know all these structures develop from first and second arch mesenchyme as well. The pinna and also hillocks of his, that is very important. Then the most important thing is external aortic develops from first pharyngeal arch cleft, means ectoderm. Okay. Whereas middle ear and station develops from first endodermal outpoaching from a structure called tubotympanic recess. I repeat it. External ear from ectoderm, middle ear from endoderm. This tympanic membrane from all these three layers, and malleus, incus, and the muscles are associated with it develop from mesoderm. So ectoderm, external ear. This malleus, incus, stapes, mesoderm. Middle ear cavity, which is called first ectoderm. This is middle ear cleft and east tissue develops from endodermal outpoaching. So all three layers now tympanic membrane, very important. I hope you understood. Some of the syndromes and anomalies associated with embryology. To look at this particular, the hillocks of his, if it is defective in formation, it results in a disease called pre-auricular sinus. You would have seen such sinus in many people. Unless until it is symptomatic, you don't have to do anything. Okay, if it is asymptomatic, you leave it. If it is symptomatic, you do surgical excision. All right. Yes. Next one is coloral fistula. I have told you The external article develops from the first ectodermal cleft. In that case, if external article development is defective, that is a disease called coloral fistula. This is called coloral fistula. Called coloral fistula. So what you have to understand, it's the first ectodermal cleft defect. The treatment is surgical excision. That's all. Okay. Fine. So just listen to the name of these syndromes: Treacher-Collin golden hair syndrome. You would have heard of a lot of syndromes, like 50, 100. If at all a syndrome should have hearing loss, that hearing loss will be sensory neural hearing loss. Only two syndromes will be having current hearing loss. Those syndromes are these two syndromes: Treacher-Collin syndrome and golden hair syndrome. Why? As I have told you, the first and second pharyngeal arch results in the formation of external and middle ear. If such pharyngeal arches are defective or not forming well, that results in these syndromes. Okay. So Treacher-Collin golden hair syndrome are having current hearing loss. That's the most important MCQ. Middle ear anatomy is very important, out of which the medial wall and posterior wall is pretty important. So lateral wall, so it's quite easy. You see the tympanic membrane, that's the lateral wall. Then the tympanic membrane has parts such as pars tensa, pars flaccida, cone of light, and umbo. So these are the parts of the tympanic membrane. You could see bony projection called scutum coming from the superior end. That superior end is very important. That superior end will mount, or it will be holding the tympanic membrane firmly in place. Okay. So now coming to the next wall, anterior wall. The anterior wall has canal for tensor tympanic, canal for eustachian tube, and canal of Hoogier. Kindly pay attention: canal of tensor tympanic, canal of eustachian tube, canal of Hoogier. This canal of tensor tympanic is for tensor tympanic tendon. The eustachian tube is for eustachian tube, that you know very well. The canal of Hoogier is a new one. This canal of Hoogier is the exit point for cauda tympani. Now, exit point for cauda tympani. So I'm just going to show the various walls of the middle ear. So if you look at this particular three-dimensional depiction, you will never forget. It will be easy for you to remember and recollect things. Okay. So I'll not waste much time. You just peep into it. We'll then proceed to the topics. Okay. Can you look at this? This is the lateral wall of the middle ear. This is the tympanic membrane. This is the normal appearance of the tympanic membrane. Can you look at this? This is pars tensa, pars flaccida. It's a bright tympanic membrane. So these are the normal tympanic membrane findings. So I'm going to remove the normal tympanic membrane. Okay. So once I remove the normal tympanic membrane, what I'm going to see? I'm going to see in the ear ossicles. So let me tell you what are the ear ossicles, how they are arranged. The arrangement of the ear ossicles is very important because that will assist us in receiving the sound and connecting the sound, creating the sound stimulus and action potential. Okay, see, look at this beautifully. This is the handle of malleus. Once you see the handle of malleus, you could go a little bit. See, beautifully we could see. This is malleus. This is surely I'm tilting incus for you. So this is called incudomalleolar joint. This one is incudomalleolar joint. This one is incudostapedial joint. Here you could see the cauda tympani now going just below the handle of malleus. That's also important. Now you need to understand about two important muscles. One is, can you see here? This is stapedial tendon attaching to neck of the stapes ossicle. Then anterior wall, you could see the tensor tympani tendon. Can you see tensor tympani tendon? If you look at the left hand of your screen, so this is tensor tympani tendon coming from the anterior wall and attaching to the malleus. So this completes the discussion about the important structures of the middle ear. Okay. So lateral wall is very easy and very important. Scutum is the bone that is coming from above and attaching it. So anterior wall, very important. Medial wall. So medial wall is having a prominence of cochlea called promontory. Two windows called oval window where the footprint of stapes connects. A round window which is called second tympanic membrane. Two bony projections. One is called ponticles, another one is called subiculum. These two are strategically very important by the name goes. Okay. So posterior to promontory, we are having two bony projections called ponticles above and subiculum below. Okay. So this process cochlear is an important structure that's found at the anterior superior end of the medial wall. So it is an attachment for tensor tympanic. It is an attachment for tensor tympanic. Then we are having two bony coverings. One is over the facial nerve, another one is over the lateral semicircular canal. Let me show you the structures. If you understand this now, it will be very easy for you to so look at this medial wall of the middle ear. This medial wall of the middle ear is very important. So give me a second. So you just look into this medial wall of the middle ear. So under middle of the middle ear, you will first see the promontory. Then posteriorly, you will see the oval window. Then just below it, you will see the round window. Again, it's hanging. So let me show you some other times it's hanging. I don't know why. Sorry. Okay. So let me show you some other times. Sorry. Okay. So you just look into this medial wall of the middle ear. So we have to underline the points and understand the points. Prominence of cochlea is called promontory. Two windows, oval window, round window, two bony projections, and process cochlear forms an important attachment for tensor tympanic tendon. Two bony coverings for facial nerve and lateral semicircular canal, very, very important. So we are having three semicircular canals. One is posterior semicircular canal, superior semicircular canal, and then lateral semicircular canal. Okay. So out of these three semicircular canals, one semicircular canal is having boundary with the medial wall of the middle ear. Then posterior wall, very important, pyramid. It is an attachment for stapedius tendon. One space is above the pyramid, it is called facial recess. One space below is called sinus tympani. Roof, tegment tympani, floor jugular bulb. That completes the anatomy of the middle ear. Let's get into the contents of the middle ear. See, I have shown you the malleus already. This is the malleus, which is hammer shape. Handle of malleus forms the prominence of the tympanic membrane. The tensor tympani, which is the muscle which is getting attached to the malleus. So it has a nerve supply of mandibular nerve, which is the nerve supply of first pharyngeal arch. Whereas, just look at the incus, it looks like an anvil. Okay, so an anvil shaped bone has least blood supply, more prone for erosion because it has least blood supply. If they ask you which ossicle is more prone for erosion, you should answer it as incus. Short process of incus in fossa incudis is a surgical landmark for facial nerve. So stapes. Stapes is stirrup shape, smallest bone in the body. The footprint of stapes with antral ligament closes the oval window. The stapedius is starting from femoral eminence. It is given by facial nerve. Okay, the nerve supply of stapedius tendon is facial nerve. So now important anatomy of inner ear. Okay, so inner ear is divided into bony labyrinth, membranous labyrinth, and sensory epithelium. So when we consider the bony labyrinth, membranous labyrinth, we just look into this picture. It's beautifully seen. So the labyrinth looks like a snail. Okay, you have seen a snail with a shell behind. So if you remove the bony labyrinth, okay, if you remove the bony labyrinth, you will see the membranous labyrinth within it. Okay, so we are having three bony labyrinths. One is cochlea, two is vestibule, three is semicircular canal. Within every bony labyrinth, you will see a membranous labyrinth. So the bony labyrinth within the cochlea is called cochlear duct. The bony labyrinth within the vestibule is called atrial saccule. The bony labyrinth within the semicircular canal is called semicircular canal duct. Can you understand it? See here, this is the cochlear duct which is having turns. So this is the atrial and saccules which are found within the vestibule. These are the semicircular canal ducts. Can you see? These are the semicircular canal ducts. So how it looks like? A snail body. Within the snail body, you will be having a jelly body. No. Similarly, there will be a membranous labyrinth outside and a sensory epithelium inside it. Okay. So just look into the classification which I have put forth. See, this is cochlea. Alright. Cochlea is a body labyrinth. The membranous labyrinth of the cochlea is called cochlear duct. The sensory epithelium within the cochlear duct is called organ of Corti. This is meant for hearing. Very, very important. So, what is sensory epithelium for hearing? They will ask, it is organ of Corti. What is the bony labyrinth? What is the membranous? Very, very, very important. So, now come back to the next thing, vestibule. So, the vestibule is a bony labyrinth which is having membranous labyrinths of atrial and saccule. The sensory epithelium within the atrial and saccule is called macula. Okay. The next one. So this is meant for linear balance. You're going in a bus. The bus driver suddenly applies brake. You will be experiencing sudden vertigo and jerky movement. That is called linear balance. This linear balance is maintained by atrial and saccule of the membranous labyrinth within the vestibule. Okay. So next one is semicircular canal. So the semicircular canal is a bony labyrinth. The membranous labyrinth within the canal is called semicircular canal duct, and the sensory epithelium is called crista ampullaris. It is called crista ampullaris. All right. Now you have to understand the difference between inner hair cells and outer hair cells. To understand that difference, you should remember the comparison between inner hair cells and outer hair cells. See, inner hair cells looks like a consultant in a hospital. The consultant, though they are less in number, they will be very happy. They have close contact with the management. Whereas the resident doctors, okay, so after you are passing your FMGE exam, anyways, you are going to be the residents of that particular hospital, be it whatever hospital you are going to choose. Okay, so my dear students, you are definitely going to crack this exam. Okay, you are going to become a resident. So after becoming a resident, so what are the features of resident? More in number. Okay, so though it is more vulnerable, it is easily, like it is more vulnerable like a resident. The interns and postgraduates are easily getting beaten by the patient attenders. Similarly, these types of cells are very vulnerable, but it has not any significant contact with the central pathway. Okay, so that is the basic difference between type 1 and type 2 hair cells. Okay, very, very important. Then, so how is a sound from external atmosphere getting into the inner ear or getting into the brain? The first one, we are having tympanic membrane, which receives the sound vibration, then to the ossicles, then to the inner hair cells. Then the inner hair cells produce ionic gradient that spreads into eighth nerve, which is a cochlear nerve. Very, very important. Eighth nerve, which is a cochlear nerve. Then cochlear nucleus. Then superior olivary complex. Okay. Then lateral lemniscus. Then inferior colliculus. Then middle genital body. Then auditory cortex. Very, very important. You should never forget this mnemonic ecolema. Should never forget this mnemonic ecolema. So it's pretty important. Okay. So we are going at a good one. Okay. So next one. So there is a important physiological balance given off by the body called impedance matching. So whenever any energy jump from one medium to another, there will be significant loss of energy. Similarly, the air molecule having the sound initially getting transferred to the solid molecules. After solid molecules, it is getting into the perilymph and endolymph water molecules. So it has almost jump of medium to medium almost 3 times. So with this aspect, if we are hearing now, our hearing will not be this much effective. So the main role of this impedance matching is very obvious, okay, so that we could hear the sound better, though we are not able to hear the minute frequency changes. So what is an impedance matching? First, we are going to compare the length of the malleus with length of incus. So the length of malleus will be 1.3 is to the length of incus is 1. So it is almost 0.3 the percentage of times better than the incus. Okay, this is called 1.3 is to 1. It is called lever ratio. The second one is area ratio. So directly we are comparing the bigger surface area with smaller surface area. So if you do like this, you will be having a area ratio of 22 is to 1. So 1.3 is to 1, 17 is to 1, multiply both, 22 is to 1. Very important. Okay, it's very important. Okay, fine. With that note, we have completed physiology of the ear. Okay, so it starts from tympanic membrane ossicles. From right from the fighter only, we are naming it as ecolema. Eighth nerve, cochlear nucleus, ciliary complex, lateral lemniscus, inferior colliculus, middle body, auditory cortex. Very, 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 very important. Okay, so let's get into the important investigations for hearing loss. Okay, what are the important investigations for hearing loss? We are having air conduction better than bone conduction. It is Rinne negative. Bone conduction better than air conduction. It is Rinne positive. If you are having a Rinne negative, it is normal or sensory loss. Rinne positive, it is conductive loss. Okay, so you just have to keep the tuning fork behind the pinna. Once the patient stops hearing, ask the patient to raise the hand. Then keep the tuning fork in front. You will hear the cling sound. So if you hear the cling sound, air conduction better than bone conduction, either it is normal or sensory loss. Okay, so if it is opposite, if bone conduction better than air conduction, it is Rinne positive. So there is conductive hearing loss. So that we could diagnose the Rinne positive, whether it is conductive loss or sensory loss. Then the important test, V-Bose test, very easy. So you have to place the tuning fork over the glabella. If it is lateralized to the affected side, it is sensory loss. If it is lateralized to the better side, it is. So if it is lateralized to the better ear, it is sensory loss. If it is lateralized to the affected ear, it is conductive hearing loss. Okay, so very, 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 very important. Okay, very, very important. Then absolute bone conduction. If the bone conduction of the patient hears that of the examiner, so you ask the patient, you raise your hand once she stops hearing. Once she stops the hearing, indicating that she has stopped hearing the bone conduction, you could keep that bone, a similar rod in your ears. If you still hear now, your hearing is better, patient hearing is worse. So it is indicative of air bone conduction positive, which is sensory neural hearing loss. Okay, fine. So that's all about the pure tone audiometry or audiogram. All are one another the same. Pure tone audiometry or audiogram, all are one other the same. Okay, now this question they are asking repeatedly: rules for plotting the audiogram. Okay, when you are plotting the audiogram, what are the important rules? Okay, if you understand and remember the rules, you could easily diagnose any question coming out of this audiogram thing. Okay, the first one is you should find whether there is any curve which is more than 25 decibel mark. If any curve more than 25 decibel mark, it is confirm of hearing loss. Any hearing loss, SNHL or CHL, we are not confirming at this junction. Any curve more than 25 decibel mark is hearing loss. Then bone conduction curve more than 25 decibel mark, it is sensory neural hearing loss. Once finishing the second rule, go to the third rule. More than 10 decibel, it is conductive loss. Less than 10 decibel, it is sensory neural hearing loss. Okay, now I will show you a graph and I explain with that. You just look into the graph. Can anyone say what hearing loss is this? I want you people to answer. Only you are, if you are answering or not, I will proceed further. We are having a small group. I want you to answer. Dr. Jennifer, Dr. Gaurav, Dr. Dilesh, Dr. Dilish, Dr. Dev, Dr. Arun Kumar. So it's short group. So you're not answering now, I will ask you to show the camera. So because I'm taking it for you, you should be understanding it. Can someone type in the chat box? This curve looks like what? Conductive hearing loss, or it is sensory loss, or mixer loss? Anything? Please answer. So I can't hear with your voice. Okay, I switched off the microphone. Please type in any content. What is the diagnosis of this particular thing? If you're not answering, I'm not proceeding further. I want you people to answer. Dr. Dev, Dr. Dilish, Dr. Gaurav, Dr. Jennifer. So Dr. Dilish has opened the account. Okay. Any other else? Any other answers? This curve right in front of your screen. What do you call this curve? Pass. Okay. You pass this question. Fine. SMHL from Dev. Okay. Others. Jennifer. What are you saying now? So let's be interactive. We are having a small group. I want you people to learn something. It's not a monotonous lecture. Okay. If you keep on reading now, it's not useful for you. Only 4, 5 of you are there. I'm ready to explain you any concept. Okay. So every people over there, please listen to this again. I will ask you again. See here. So this audiogram graph will be plotted from above to below. Okay, you are giving an answer, Dr. Gaurav. Thanks, so nice of you. I will explain you now. See, doctors, this audiogram is plotted from above to below. Understood? This audiogram is plotted from above to below. So 25 decibel is normal hearing. Okay, 25 decibel is normal hearing. So if you are having both the curves, air conduction curve, bone conduction curve, less than the 25 decibel range, you can call the hearing as normal. So which comes to a first thumb rule. If any curve more than 25 decibel, there is short possibility of getting hearing loss. Okay. So we have confirmed it as hearing loss. Now we have to confirm whether it is conductive hearing loss or sensory neural hearing loss. Okay. So first, what you have to do, 25 decibel mark. Okay. So all 5 of you, Tamil, do you know Tamil? Do you find it easy to hear in Tamil, or shall I proceed only in English? Dr. Dev, Dr. Dilish, Dr. Gaurav, Jennifer, anyone? So English is okay, wa? Or do I need to teach you in Tamil? English is okay for Dr. Gaurav. Okay. One is saying English now. I should be taking only in English. I'm sorry. Okay, fine. Hey, please listen, pa. Okay. See, let me explain again. The first thing you have to know is any curve, whether it is more than 25 decibel or not. Point number 1. Point number 2, if only bone conduction curve, you have to look into the picture. How can you identify a bone conduction curve? It's very easy. If the lines are broken like this, Dr. Gaurav, can you understand this? If the lines are broken like this, it is bone conduction. If the lines are continuous like this, it is air conduction. So broken lines, bone conduction. The second important thing, if the line is red in color, it is right side, R. If the line is blue in color, it is left. Okay. So if they Okay, Dr. Gaurav, no other have answered. Okay, so none of them has asked for any Tamil request. Okay, so as no one has asked me any request, so I'm going with your request. Okay, so other before people didn't say anything. Okay, so I'm okay with this. Okay, see, my aim is you should be answering 10 questions from ENT part. So I've made it as a high yield discussion. So please be with me. Okay, fine. So Dr. Gaurav and others, you just look into this. So if it is a right-sided curve, red color. Blue color curve means left-sided. Okay, that is rule number 1. Then we have to know the shapes of the curves. See here, if it is less than or greater than, it is bone conduction curves. Less than or equal, greater than symbol. If there is, if it's there now, you should be. It is bone conduction curve. Or 0x. 0 is right, x is left. Okay, this is rule number 2. Rule number 3, the right for red, left for blue. So these three rules you should never forget. Rule number 1, less than greater than for bone conduction. 0x for 0 for right side, x for left side air conduction. Okay, Papa, fine. Now we have to apply all the thumb rules in any audiogram graph you should be seeing. The rule number 1, whether you are having hearing loss or not. If I take an audiogram for you, you will not be having any audio. You will not be having any hearing loss, which states that if you are having less than 25 decibel curves, it is normal. If you are having more than 25 decibel curves, any curves, whether it is air conduction or it is bone conduction, you will be having hearing loss. That is point number 1. Point number 2, bone conduction curve more than 25 decibel mark. Only bone conduction. See beta. So you should be seeing only the bone conduction curve first. If it is more than 25 decibel mark, it is sensory neural hearing loss. Now you come to the third option, air bone gap. If it is more than 10 decibel, conductive hearing loss. Less than 10 decibel, it is sensory loss. Okay, now look into this picture. Okay, Dr. Gaurav or Dr. Dev, apply the three thumb rules over here. What is rule number 1? Hearing loss is present or not? Yes, of course, hearing loss is present because one curve is more than the 25 decibel range. Okay, understood? Fine. The second one, what is thumb rule number 2? Dr. Jennifer, please answer. Dr. Jennifer, you could either type or you could even answer. Dr. Jennifer, what is thumb rule number 2? How the thumb rule number 2 is applied to this particular scenario? Please answer. Jennifer, okay, I'm not getting a response from Jennifer. Okay, Dr. Dev. Oh, Dr. Dev, what do you think of this particular thing? What is the second thumb rule and whether it is satisfying second thumb rule? Someone please answer. If you are not answering, it is very clear that you are not understanding. Okay, if you are not understanding, I'm not going to proceed further. So whatever minimal topics that you understand, it's happy for me. Okay, Dr. Dev has opened the account. See, this is a red colored line. So right, you are brilliant. Then, so red color, right? This one, this less than symbol is bone conduction part. People, this bone conduction is normal. Can you see this? This bone conduction is normal. Only if there is something over this line, you call it as abnormal. Okay, va? And only when you call something over this line, you call it as abnormal. Fine, pa. So in this picture, first thumb rule, hearing loss is present. Yes, present. Thumb rule number 2, bone conduction curve more than 25 decibel. No. Okay, it is not more than 25 decibel. It is less than 25 decibel. So no sensory neural hearing loss is present. Thumb rule number 3. What shall we do? Air-bone gap. What is the air-bone gap over here? Someone please answer. Dr. Divish. Dr. Dilish.
Yes, sir.
What is the air-bone gap in this diagram? Please answer. It's a small group. You're not answering. It is highly monotonous. I can't proceed further. Please answer. Dr. Dilish. So it is 25 decibel. Thank you for answering Dr. Jaiprakash. Okay. The third thumb rule, air-bone conduction more than 25 decibel is more than 10 decibel. Okay. So all 3 thumb rules are satisfied. Okay. All 3 thumb rules are satisfied. It is right-sided conductive hearing loss. This only I am spending this much time. Right-sided conductive hearing loss. Understood? Okay, now Dr. Jaiprakash. Now, please apply thumb rules in this picture. Dr. Jaiprakash, what is thumb rule number 1? What is thumb rule number 2? What is thumb rule number 3? Come on. See, very important topic. If you don't understand this now, there is no use of me coming to you and teaching you. Someone please answer.
Sensory neural hearing loss.
My question is, thumb rule number 1 is satisfied or not? It is satisfied. Gaurav, you have answered it very correctly. You are great, good going, pa. See here, let me tell you 3 thumb rules again. See, this is 25 decibel range, pa. Both the curves are more than 25 decibel range. There is hearing loss, number 1. Number 2, bone conduction curve is more than 25 decibel. Yes, okay. Number 3, air-bone gap less than 10 decibel. So all 3 are confirmatory of right-sided sensory neural hearing loss. Okay. Now have you understood? Now let me tell you another picture. Now, yes, Dr. Gaurav, all 3 have checked. Now apply the 3 thumb rules for this particular diagram. Anyone please answer? Hello, Dr. Jennifer, Dr. Dilish, please answer. So apply the first thumb rule, Dr. Dilish, whether it is correct or not.
Hearing loss is there, sir.
Hello, anyone is there?
Yes, sir.
Please tell something.
Hearing loss is there, sir.
Anyone? Please answer. First one is checked. Hearing loss is yes. Hearing loss is present. Thank you for answering. Hearing loss is present. Number 2, you please look into this. It's 25 decibel range. So both the bone conduction curve is more than 25 decibel range. Okay. So point number 2 is satisfied. This case is having sensory neural hearing loss. Thumb rule number 3, air-bone gap. What is the air-bone gap here, Dr. Jennifer or Dr. Dilish? What is the air-bone gap here? How many decibel air-bone gap is there? So it is 25 decibel. Dr. Dilish, good going. So now look into this. This is a case where the patient is having both conductive hearing loss and sensory hearing loss. It is mixed hearing loss. Okay. If you don't apply my 3 thumb rules, you will never find out the mixed hearing loss. You will mislead. Okay, so you should not mislead yourself. You should be applying for all the 3 thumb rules so that you will always arrive at the correct diagnosis. Okay, fine. There are a few conditions which are having specialized audiogram patterns. This is Gerard's notch. The Gerard's notch is seen in otosclerosis. These are one-liners. The 4000 Hertz dip is seen in noise-induced hearing loss. Then low frequency sensory hearing loss is seen in Meniere's disease. So sloping or high frequency sensory loss is seen in age-related hearing loss. Cookie bite pattern is seen in congenital deafness. All the 5 are very important. They may ask as an MCQ. Okay, Opa? Okay. So already learned many things about this. So let's solve MCQs from your FMGE. Which of the following conditions will cause bone conduction in pure tone audiometry? Can you please answer? Okay. So we'll solve this MCQ. Then I'll again explain the audiogram. See here, we are having 2 hearing loss. One is conductive loss. Second one is sensory loss. Okay. So the third thumb rule, the thumb rule number 1, both the curves more than 25 decibel. Hearing loss is present. Thumb rule number 2, broken lines. If the broken lines more than 25 decibel, na bone conduction confirmed. Whether the disease has occurred in the middle ear or not, okay, don't worry about that. Less than 25 decibel, bone conduction is normal. More than 25 decibel, bone conduction is abnormal. Okay, fine. The third one is air bone gap. If the AB gap is less than 10 decibel, it is sensory neural hearing loss. More than 10 decibel is conductive hearing loss. Okay, so if we apply these 3 thumb rules, hearing loss is present. Thumb rule number 1 confirmed. Second thumb rule, sensory loss is present because the curve is more than 25 decibel. Wrong. Correct. AB gap more than 10 decibel. Okay, AB gap is more than 10 decibel. It is conductive hearing loss. So this is a special situation. Okay, where there is both conductive loss and sensor loss. Okay. So with this aspect, how can you going to treat the child? So if you, yes, you got it right. Yes. Okay. Which of the following step there are we didn't study? So now we will look into the question. The TM perforation step is ESC pathology. These are all middle ear or external ear pathology. The only inner pathology is cochlear pathology. Okay. You are all answered it correctly. Thank you so much for answering. Okay. This question will solve once we finish here. We'll come back again. Okay. So I'm going to tell you a story. It is called Approach to Hearing Loss. Okay. So there is a bigger house which is present inside a city. The house owner has went abroad. He has made 4 dogs to guard and monitor the house. Okay. One fine day, yes, a thief is coming out of a manhole and is getting into the premises of the house and is trying to cheat. Okay. So this is a scenario. So the dog barking and the thieves are escaping. It is called acute otitis media. The dogs are barking and thieves are escaping. This is called acute otitis media. Then, if the dogs are not clearing the infection, if the thief has an upper hand, so it enters into the middle ear as CSOM or COM. And this is the middle ear as chronic otitis media. All right. Now there are few conditions which causes air fluid levels within the intact TM. Okay, air fluid levels within the intact TM. Okay, that is called serous otitis media. Dogs barking without any teeth, it is called serous otitis media. So this is not an infective condition. This is mechanical obstruction of the TM. So in this case, antibodies are not effective. So you should be taking impedance audiometry. So impedance audiometry, if it is an early SYM, it is HIPS type C. If it is late SYM, it is fluid filled air bubbles is present. Okay, fine. Okay, so what is the treatment for otoacoustic emission or SOM? Okay, treatment is we should be giving adenodectomy with grommet insertion. Okay, adenodectomy with grommet insertion is the treatment for SOM. If this occurs in an old age person, you should be taking biopsy and you should operate accordingly. Okay, taking biopsy and operating. The second thing is this TM getting involved and inflamed. Inflammation of that tympanic membrane is called as acute otitis media. Acute otitis media, we are having few stages. You should be knowing only the important signs. The sign is sign of suppuration, which is lighthouse sign. So lighthouse sign positive is due to sign of suppuration seen in acute otitis media. Okay, so see here, from the nasopharynx, the infection has entered into the middle ear. This middle ear has attained an infection called acute otitis media. Okay, so once this acute otitis media is not able to dissolve correctly, it is reaching to the level called chronic otitis media. It is reaching to a level called chronic otitis media. So let me tell you the classification of chronic otitis media. It is divided into mucosal type. The other is called tubotympanic type or safe type. So we are seeing about CSOM classification. It's divided into two types: mucosal disease and squamous disease. Okay. So the other names for mucosal disease are tubotympanic type and safe type. Okay. The other names for squamous disease are atticoantral disease, squamous disease, or unsafe disease. So this chronic otitis media is not divided based on classification to past tensa, past. So not like that. Okay, it's not divided based on the disease. Okay, it is divided based on the pattern of epithelium, mucosal disease or squamous disease. It is divided based on that only. Okay, so if it is discharge is coming out of the perforation, it is active. No discharge, inactive. Now there is a situation where the TM gets healed by itself, which is called adhesive otitis media. It is commonly seen at 5 or 7 years after surgery. Okay, squamous disease. So it is an acute, active, or inactive. It is inactive, so this subtraction bucket is not included. Okay, so the active squamous can be included. Now, we saw an MCQ from FMGE 2018. Mainstay treatment for glue ear. Everyone, please answer. Please answer, pa. Yes. Combination, you are answering correctly. Okay. Others also, please answer, pa. Please answer. Let me get some water. Please answer. Please answer. Hello. Whatever you you are taking it is, please answer. Okay, fine. So running answer is D correctly. So what is this part? This serous otitis media is nothing but we are having fluid filled middle ear. It's just having fluid. There is no infection. So we don't have to give any antibiotics or decongestant. That will not be so much effective. So this is called myringotomy with grommet insertion. Okay. So we are putting an incision over the tympanic membrane. The tympanic membrane name is called myring. Okay, we are putting an incision on the tympanic membrane. It's called myringotomy and insertion of grommet. Myringotomy with grommet insertion. Can you get my point? Okay. Now let me introduce you to the symptoms of the chronic otitis media. And the first symptom is ear discharge, hard of hearing, ear pain. Very, very easy. So the patient is having a perforation of tympanic membrane. So there will be an ear discharge. Hard of hearing due to tympanic membrane perforation and erosion of the ossicles. They will not hear it very clearly. Okay. So this one is very important. Third one is ear pain due to some inflammation going on and off. Okay. Now you just look into this. All these three symptoms will be present in safe type as well as unsafe type. Now in unsafe type, you will be having a ear discharge. It is foul smelling. You will be having a foul smelling ear discharge. So foul smelling ear discharge in unsafe type. Okay, in unsafe type. All right. Okay. Fine. Now you just look into this. There will be a chronic negative negative pressure of the middle ear, which is leading to a retraction packet. So what is the concept behind this retraction packet? See, you are celebrating a birthday. For birthday, you will be pumping the balloons. If you leave those balloons for 20 days or 30 days, what will happen to those balloons? It will deflate by itself. So leaving a chronic negative pressure without touching it now, it will lead to deflation of a cavity. Similarly, the middle ear cavity, which will be intact, due to negative pressure in the middle ear cavity, it will slowly deflate by itself. Okay, so deflation of the middle ear cavity is called retraction packet. That is an important pathogenesis for this polycytoma formation. Okay, let me explain other theories. Theory number one is, I have already told you, Wittmann's theory. It is retraction packet theory. Theory number two is Habermas theory, migration through a perforation. Theory number four is S for S, Sadie's theory, Thomas metaplasia. Then Rudy's theory and basal cell hyperplasia. All right. Fine. Now I am having the CSOM. With the CSOM, I am going to get my ears with ear discharge, hard of hearing, ear pain. Sometimes may even lead to complications inside my brain, facial palsy, whatnot. Okay. So in that case, I am having two types of treatment for such conditions. Number one is hearing reconstruction. Number two is disease clearance. So we are having separate treatment modalities for these two. First, it is very simple. The ossicles are gone. We are going to reconstruct ossicles and tympanic membrane. This is called tympanoplasty. So ossicle or the tympanic membrane are gone. If we are going to reconstruct the ossicles or tympanic membrane, it is called tympanoplasty. My gentle question, if someone wants to write in a tab or iPad, do you need this PDF right now? Anyone? If you want now, I will send to Robin, he will send you. Anyone need this PDF right now so that you could write notes over it? Anyone need this? Please answer. If you want this now, I will send you right now so that you could write it over the PDF in your iPad or this tab, whatever. So please answer at least. If no, na, tell no. Yes, they doesn't need anything.
No.
So I got one no response. So others, shall I take it as you don't need a PDF? You are just listen. Yes, most of them don't need. Okay. So is this session okay? Is my energy levels okay, pa? Shall I proceed? Okay.
Yes, please continue.
Okay, we'll proceed. Okay, fine. We're going to finish as many as possible. Okay, it is going to be a fun-filled session. So type 1 meringoplasty. Just look into this. So we are having ossicles. Can you look at the ossicles? See, pa. So these are the ossicles. This is the tympanic membrane, pa, which is holding the malleus. Tympanoplasty number 1, malleus alone, tympanic membrane alone gone. So I am going to introduce my graft and place it over the graft over the malleus. This is tympanoplasty type 1. Now, number 2, tympanoplasty number 2 is this cholesteatoma disease has caused tympanic membrane perforation and also it has caused malleus erosion like this. Can you see, pa? In this picture, malleus gone. So now I am going to introduce my graft or cartilage over the incus. This is tympanoplasty number 2. Okay, type 2 tympanoplasty. Now, next one, incus also eroded. So if the patient is having only stapes of foot plate which is available, we are going to place the cartilage over the stapes suprastructure. So stapes has two parts, suprastructure and foot plate. If the stapes suprastructure is still there, we are going to place the graft over it. This is tympanoplasty number 3. If foot plate is alone intact and placing the cartilage over the foot plate, which is called as tympanoplasty type 4. At 5 and 6, you don't have to know, it is very tougher to understand. You just have to remember type 5 is fenestration procedure, type 6 is sono inversion. Understood? So I'm just repeating it. Tympanoplasty is very important. Type 1 is placing it over the malleus, only TM perforation is there. Type 2 placing it over the incus. Type 3 placing it over the stapes superstructure. Type 4 placing it over the foot plate of stapes. Type 5 is called fenestration procedure. Type 6 is called sono inversion. Clear? Fine. These 3 names are very, very important. Say I'm going to operate upon the patient behind the ear or in front of the ear. Okay, I am having 3 incisions which are very commonly used. Rosen endomeatal. This is external artery meatus. Through that, if you are putting an incision, is called Rosen's endomeatal incision. Very important. So there is an area called incisura terminalis, which is devoid of cartilage. Placing incision over incisura terminalis, which is devoid of cartilage. It is called Lempert's endoral incision. When placing an incision over the incisura terminalis, it is called Lempert's endoral incision. Then the most commonly used incision is modified William-Weld incision. So with the patient having disease, we are putting an incision behind the ear that is called post-auricular modified William-Weld incision. This is the most commonly used incision for almost all the ear surgeries. Okay, these are the surgical names. Then I'm going to do a surgery for my patient called cortical mastectomy or canal wall of mastectomy. Kindly gel into these names: cortical mastectomy or modified radical mastectomy. You should be definitely knowing these names. Okay, so if I'm going to do a surgery, I want to remove the mastoid cells. Okay, if I want to remove the mastoid cells, I want to put a post-auricular incision, and I should identify mastoid cells. The mastoid cells which is more prominent and consistent and acts as a good reliable surgical landmark for doing the surgery, it is called mastoid antrum. Okay, it's called mastoid antrum. So to identify this mastoid antrum, we are having a triangle called McEwen's triangle. So under this McEwen's triangle, we are having three lines. One is supramastoid crest line. Second one is external ear canal posterior line. Okay. Then a tangent joining these two lines. Okay. So these three are the lines. So now you will get a triangle shaped structure. Through the triangle shaped structure, if we drill through the bona, it is called as cortical mastoidectomy. Okay. Let me give you a small example how it is being done. Okay. So this is going to be a fast session only, but I will never leave anything so that you will always be thorough with things. Okay. So just look into this. This is a surgical demonstration of cortical mastectomy. So this patient is lying in a position called semi-fowler position. Semi-fowler position. This is a tympanic perforation. Okay. So we are going to freshen the margin and we are going to elevate the tympanomeatal flap. Once we have done this, we are going posteriorly. See, can you see? This is the McEwen's triangle. Can you see? Triangle shape. So once I see the McEwen's triangle, I am going to drill the bone. So the drilling should be continued till the mastoid antrum. Okay. So once the drilling has been complete, so we have established communication between the middle ear in front and mastoid cell cavity behind. So this marks the completion of our surgery. Okay. This is called cortical mastectomy or canal wall of mastectomy. There are having two mastectomies. One is canal wall up mastectomy. Another one is canal wall down mastectomy. We are removing the canal wall. It is canal wall up. Otherwise called cortical mastectomy. We are sacrificing the canal wall because we are not able to give disease clearance with a small opening. To have a bright, elaborate opening, we are doing a surgery called canal wall down mastectomy, otherwise called modified radical mastectomy. So if you are having a safe type of CSIM, cortical mastectomy is enough. If you are having unsafe CSIM, you need a modified radical mastectomy. Safe CSIM, only TM perforation. Unsafe CSIM, so unsafe CSIM, we will be doing MRM. Okay. In cholesteatoma. Okay, fine. So canal wall up mastectomy, canal wall down mastectomy. So we will be doing this in unsafe type of CSIM. All right, got it, pa? Yes. So another important topic: complications of CSIM. So the commonest complication that you could see is temporal lobe abscess. If you see a abscess over the temporal region, it is temporal lobe abscess. The important features are homonymous hemianopia and nominal aphasia. If the patient is not able to repeat the names of the familiar persons or friends, it is called nominal aphasia. So this aphasia is selective only in temporal lobe abscess. That's the important thing. Second one is brain abscess. The cerebellar abscess can happen if the CSIM can breach a triangle called Trotman's triangle. If CSIM can breach a triangle called Trotman's triangle. Okay, fine. So in this picture, cerebellum is involved, means there is cerebellar abscess. there will be cerebellar signs positive. There will be cerebellar signs positive. Okay, fine. Next one, meningitis. A patient coming to you with headache, high-grade fever, projectile vomiting, neck rigidity, Kernick sign and bruising sign positive. This you would have learned in medicine. Kernick sign and bruising sign positive. If you have all these features like headache, high-grade fever, projectile vomiting, neck rigidity, Kernick and bruising sign positive, it is meningitis. So this can also happen as a result of CSIM. See, CSIM is not a simple disease. It could cause a lot of complication, and even the patient could die following CSIM. That's why you should be very safe with CSIM. Especially the cholesterol part is very, very dreadful. So otitic hydrocephalus, these can happen if a lot of abscess are happening. That will increase the pressure inside the brain. That increased intracranial pressure can lead to a condition called hydrocephalus, which is otitic hydrocephalus. Hydrocephalus can happen due to a lot of conditions. If it is happening due to ear noise, it is called otitic hydrocephalus. Next one, very, 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 very important. Okay, they've asked it plenty of times. So if there is thrombus particle reaching the posterior end of the mastoid artery system, there is a venous system lying over there, sigmoid sinus, or otherwise called lateral sinus. So if it is a lateral sinus thromboperitis, there should be bony erosion posterior to the mastoid artery cells, okay, that has caused thrombus inside the lateral sinus, and it has caused obliteration. So what are the features that we could anticipate if the lateral sinus had been thrombosed or blocked? The first one is picket fence fever. First one is picket fence fever. Next one is dry finger sign positive. Okay, if there is thrombosis over the mastoid emissary vein post-auricular region to the pinna, it is called dry finger sign positive. So to confirm the lateral sinus thromboperitis, okay, we should doing tests such as Toby-Eye test or Probeck test. Toby-Eye test is just looking at the lumbar puncture. Probeck test is looking at the retinal veins. Next one is a CT imaging, where the imaging doctor could give you the emptiness of that particular contrast region. Okay, empty delta sign. All right. So any doubt on that? Very important. That too, lateral sinus thromboperitis is very, very important. So kindly study well. Okay. Fine. So mastoiditis. Mastoiditis is nothing but production of pus under tension. So if there is TM perforation with mastoiditis, there could be hyperemic decalcification occurring at the bones behind the ears. Okay. Hyperemic decalcification occurring behind the bones. Okay. Can abruptly go for destroyed bones and result in a condition called mastoiditis. Okay, so infection over the mastoid hair cells, and there is intact TM. All the pus inside the mastoid. See here. This is intact TM. This is mastoid hair cells getting severely infected with pus. So once it is severely affected, it could lead to a lot of complications. So mastoiditis in itself is a complication, to lead to brain complication also. Okay, fine. So what are the clinical features of mastoiditis? Number one is fever, pulsatility discharge is called reservoir. So intermittently the discharge will be coming out. Okay, mastoid tenderness, mastoid swelling, so which gives ironed out feel over mastoid. So on looking at the post-auricular region, it will be not loose like this. It will be very tense. Okay, in that area, if you keep something now, it will lead to reservoir sign positive and mastoid ironed out feel over the mastoid. Okay. Now at the last stage, if the ear could not handle the pressure, leads to tympanic perforation and collective hearing loss. If there is tympanic perforation, there would be collective hearing loss. Now this mastoid region completely getting affected. Could it affect the nearby areas also? Yes. Nearby areas also getting affected. Okay. So steps to reduce recurrence. Okay. Steps to reduce the recurrence is complete clearance. Okay. It is complete clearance. Right. So mastoiditis resolved abscess, it is the pus getting collected into the sternocleidomastoid muscle over mastoid thick. Okay. Then ciliary is over the digastric, lux abscess over the extracortical, zygomatic abscess sitting right over there. So these are the other names for abscess. Okay, you should know this. Now, labyrinthitis. Labyrinthitis is nothing but inflammation or infection of the labyrinth due to some CSOM or any other cause. Okay. So if it is only partially affected, it is called circumscribed. If it is completely affected, it is called diffuse. So in diffuse, if it is serous, it is irritated labyrinthitis, nystagmus ulcerative. If it is suppurative, the nystagmus will be on the opposite side. Okay, so that's how it works. It's nothing but infection or inflammation of the labyrinth which is going around. So if labyrinth is infected and inflamed, what will you get? Obviously, you will get vertigo and nystagmus. Okay, you'll be having vertigo and nystagmus. So we have completed mastoiditis. Now we have completed labyrinthitis. Okay. Fine. What is petrositis? Can anyone say other name for petrositis? So you people are doing great job. So with that note itself, I want you people to answer what is the other name for petrositis. I know very well some of you definitely know the answer. Please answer. I'll be very happy to see your answer. What is the other name for petrositis?
Gradinio syndrome.
Come on, please answer.
Gradinio syndrome.
Yes, you are spot on, Dr. Jai Prakash. It is Grady-Nigo syndrome. Petrositis, otherwise called as okay, pa? Thank you for answering that, Dr. Jai Prakash. It is Grady-Nigo syndrome. It's nothing but we are having a temporal bone which is having mastoid part, petrous part, squamous part, etc. So if the CSOM from the mastoid part can enter into a petrous part of the temporal bone which is lying over the inner ear, can lead to a condition called petrositis. In petrositis, you will be having three cardinal symptoms. You just write it as 3D. The first D is discharge, second D is deep-seated eye pain, third D is diplopia. Discharge, deep-seated eye pain, diplopia. Alright? Right. That note, we'll solve some MCQs. A boy present with the history of ear discharge, ear pain, and hearing loss. On examination, redness was present behind the ear. Reservoir sign was positive. What is the most likely diagnosis? Kindly answer. Everyone. I want everyone to. Dr. Ilankathir, Dr. Sandhya, Dr. Tamil Nation. I want everyone to answer. This is an interactive session. You're going to crack your FMGE exam. Okay? Please answer. So only you are answering. Your answers will make me to move further. Yes. I want still more answers. Come on. Yes. Yes, Dr. Tamil. Yes, Dr. Dilish. So, what happened to Dr. Gaurav? Did you answer? Gaurav, where are you? Please answer. Yes, you answered it correctly, Gaurav. Dr. Jeevan Prashant. I know you are new to the discussion, but you select some answer. Dr. Jeevan, Dr. Iran Kadir, please answer something. Okay. The answer is mastoiditis. Okay, fine. Great. So a patient presented to the OPD after being slapped. Here complaints of reduced hearing and ear sensation. What is the next step for management? What is the answer? So what is the answer for this? It's a previous FMGE question. You would have learned in any app or a notebook. Yes, this is how the response should be. So, so you are very clear that we are not going to do anything now because it is called traumatic perforation. So a patient having some trauma, the trauma giving rise to perforation. Okay. So if the trauma is not recovering on its own, so what is the minimum duration? So you should wait for 3 months. This is the answer. Now, which option give the best response now? Antibiotics and follow-up. So having a perforation at the TM doesn't mean that we should not give antibiotics. We should give antibiotics and then follow-up. That will be the right option for this patient. Okay, the answer is D. Toby IR test done for 2018 FMGE. Okay, it's interesting. So every one of us would have got some scoldings or beatings from our principal or professors. Okay, but luckily we are not having some chronic perforation. Okay, so I hope it has recovered now, Dr. Gaurav. Fine, Toby IR test is done for. Yes, you are great. So if you keep on answering like this now, we would have solved all the recently asked FMG questions. You don't have to waste time, and also all these concepts it will stick into your memory. Okay, you will never ever go wrong in FMG. My aim, out of 12 questions from ENT, I want you people to answer. I want people to get 10 answers correctly from ENT. Okay, so I will make that happen for you. So dip at 4000 hertz frequency in audiometry indicates this. We are yet to answer. Okay, so the answer for this question is noise induced hearing loss. 4000 hertz dip is noise induced hearing loss. All right, fine. So it's start with otosclerosis. Okay, otosclerosis is again a middle ear disease where there will be fixation of foot plate of stapes. Now, what is happening in otosclerosis? Otosclerosis is nothing but the stapes foot plate is getting fixed. The fixed stapes foot plate is not able to conduct the sound appropriately. So for that reason, the patient will be having a bilateral conductive hearing loss, tinnitus. The patient can hear better in noisy environment. That is called a paraacusis villicide. Okay, and the patient will be having a flamingo pink appearance of the environment. That is called Schwartz-Sign positive. Okay, flamingo pink appearance, which is Schwartz-Sign. Yeah, lots of MCQs can be asked from otosclerosis. The first one is Carrot's notch. Dip at not 4000. Only bone conduction dip at 2000 hertz is called Carrot's notch positive. Only 2000 hertz dip at bone conduction. See here, this is broken lines are bone conduction. The continuous lines are conduction. So only the 2000 hertz bone conduction dip is called Carrot's notch positive. Or else you could do a impedance audiometry. In impedance audiometry, if you get a AS type of curve, it is otosclerosis. Okay. What is the treatment for otosclerosis? You could give sodium fluoride, or you could do a procedure called stepidotomy. Stepidotomy is nothing but removal of the affected bone, and we are going to replace it with the prosthesis. Okay. Removal of the affected bone and replace it with the prosthesis is called stepidotomy. Fine, super. Okay. Okay. Now we'll get into the question. Two phenomenons. One is recruitment phenomenon. Another one is rollover phenomenon. I will tell you a story. If someone is absent for a job, another one is replacing the job. That another person, if it is highly talented, his work ethics and work potential will be very good. Okay. For example, 5th standard class teacher is absent. 6th standard class teacher is coming to your class for covering. So she will be teaching more than the 10th standard class teacher. Similarly, if the lower frequency hairstyles are affected, the higher frequency hairstyles are recruited. So the patient will have abnormal growth of loudness. Okay. Abnormal growth of loudness is called as recruitment phenomenon. It is in cochlear deafness. What are the cochlear deafness diseases that you know? The first one is Meniere's disease. Second one is age-related hearing loss. Otherwise called as presbyacusis. So Meniere's disease or age-related hearing loss, presbyacusis. Second one is sudden rollover of higher intensity sounds in speech audiometry is called as rollover phenomenon. It is in retrocochlear deafness. So very, very important part. Cochlear deafness, retrocochlear phenomenon. Retrocochlear deafness, rollover phenomenon. Highly, high yield topic. Okay, fine. So for rollover phenomenon, we should be learning about an audiometry called speech audiometry. See, it's very easy. So there are two types of speech audiometry. Number one is speech reception threshold. Number two is speech discrimination score, SDS. See here, in speech reception threshold, the patient has been administered with bi-spondy syllable words, bisyllable spondy words. Okay. So what are the bi-syllable spondy words? Mama, tata, papa. So if you give recorded sounds for the patient like this, the patient should be able to repeat 50% of the words. Very, very, very important. Okay, I'm giving 10 words. The patient says 5 words. His hearing is normal. Okay, so 50% of the words able to repeat now, hearing is normal. Second one is upgraded version. Speech discrimination score. They're going to give a phonetically balanced words like Malayalam. Okay, it's a bigger concept, but it's a phonetically balanced. Okay. So if you are giving phonetically balanced words, the respondent should repeat at least 90% of the words. Okay. On repeating 90% of the words, we call that as PB max. Okay. We call it as PB max. Okay. See here, we are going to plot the PB max for normal person, cognitive loss person, sensory loss patient with retrocochlear pathology. So this normal person's and cognitive loss patient, so we'll be having a PB max like this, and it will be going steadily. So this abrupt fall of this rollover curve is called as rollover phenomenon seen in retrocochlear deafness. Okay. All right. So we're done and dusted speech audiometry. Okay. Very, very important. So what is the role of speech audiometry? For finding retrocochlear deafness. Okay, fine. The next important disease, very, very important disease, it's a gold mine of MCQs. Okay, see people, it's very, very easy to understand. So what are the structures that we are having? See here, we are having inner ear structures. This is my inner ear part. Okay, just imagine yourself. This is the normal size of the inner ear. If the inner ear is completely filled with water, it will swell up. So that will interfere with the functions of the inner ear. So this cochlea is meant for hearing. Hearing is affected. This vestibule and sensory organ is meant for balance. So both balance also affected. So the entire ear has been affected because it has been filled with too much of perilymphatic fluid. Okay, what is the perilymph? See, this is a membranous labyrinth. If you remove the membranous labyrinth, you will see the perilymph. Okay, the perilymph will be lying over this. Okay, it is lying over it. Okay, so perilymph. So excess accumulation of perilymph fluid over the membranous labyrinth and excess accumulation of endolymphatic fluid within the membranous labyrinth is called as Meniere's disease. So it is called as endolymphatic hydrops. So what are the symptoms for this patient? The patient will be having tinnitus, vertigo, fluctuating sensory loss. So it does, remember it does TVS. Tinnitus, vertigo, sensory loss. So TVS should be the order for the patient to get the symptoms. If sensory loss comes first, that is not acceptable. Okay, so that's why we have a condition called reversal of symptoms. Okay. So first tinnitus, then vertigo, then sensory loss. If sensory loss comes first, then tinnitus, then vertigo, it is called as Lermoyer syndrome. It is called as Lermoyer syndrome. All right. Now, 4 important signs in Meniere's disease: false positive visual test, Hennibert sign; sound-induced vertigo, Julio phenomenon; hearing 2 sounds in 2 different frequencies, dysplacusis. Patient can hear the loud sounds as more loud sounds. That we have already seen. It is recruitment phenomenon positive. Okay, recruitment phenomenon positive. So what are the investigation for Meniere's disease? If you take an audiogram, there will be low frequency rising curve pattern of SNHL. So it is a rising curve, low frequency. Result test will be positive. If the patient is not experiencing symptoms at this point of time, if you want to demonstrate a disease, what you have to do? You have to give glycerol for the patient. Once you give the glycerol, the patient will make themselves ready for the rise in symptoms. Okay, so without symptoms, you give glycerol that will produce the symptoms that will make you to identify the diagnosis. Okay, fine. Then the important thing is electrocoagulography. The SP by AP ratio should be more than 30%. So SP is summative potential. Okay, AP is action potential. Okay, it's very easy that. See, some 1 month back there was a concert done by A.R. Rahman. Okay, so for 40,000 occupancy of that particular concert, almost 80,000 tickets were given. So SP is the potential produced by swollen up membranous labyrinth. See, the membranous labyrinth is swollen like this. So the swollen membranous labyrinth will produce more SP. Okay, but AP will be same. So just look into this. If you are having 40,000 occupancy, 40,000 ticket na, the ratio will be 1. If you are having 80,000 ticket, 40,000 occupancy na, the ratio is 2. Similarly, if you are having SP by AP ratio more than 30%, it is clearly depictive of Meniere's disease. Understood, pa? Okay. So SP by AP ratio is more than 30%. Very, 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 very important point. The treatment is you could give Meniere device. The device will produce low pressure pulse therapy that will reduce the symptoms. Second, can give chemical labyrinthectomy, which is intratympanic labyrinthectomy. Okay, which is intratympanic gentamicin labyrinthectomy. Or else you could do a surgery. Initial surgical treatment is endolymphatic sac decompression surgery, or surgery for intractable vertigo is labyrinthectomy. Surgery for intractable vertigo is labyrinthectomy. Okay, fine. So that completes an important disease. We have completed otosclerosis, very important. Then Meniere's disease, that's very important. Otosclerosis, the disease of middle ear. Meniere's disease, the disease of inner ear. Very, very, very important. Now getting into the objective diagnosis of the ear. What is the major difference between subjective diagnosis and objective diagnosis? Subjective diagnosis, you give a sound signal, ask the patient whether you are hearing it or not. So we are relying on the response of the patient. It is called subjective diagnosis. That is only audiogram, 24 tests. All of them are subjective diagnosis. No, though we don't rely on response of patient. That is called objective diagnosis of hearing. So we are having 3 tests on it. Number 1 is autoacoustic emission. These outer hair cells will recurrently emit some energy. That energy can be recaptured by a device called OAE device. So measuring the energy released from outer hair cells is called as OAE. So 2 types: spontaneous, evoked. Okay, spontaneous, evoked. So it is used in neonatal screening because it is a portable device. So preterm infants and all are susceptible for early hearing loss or congenital hearing loss. To diagnose the congenital hearing loss at earlier point of life, even 1 week, 2 weeks children, we could do the OAE at IMCU wards. Okay, so it's a best imaging for neonatal screening, but it is not gold standard for diagnosis. It just will give a clue about the disease pattern. Okay, second one is for ototoxicity. Third one is artery spectrum disorders or artery passing disorders. For these diseases also you could do a OAE exam. So second important one is BERA, very important. BERA is brainstem evoked response audiometry. Brainstem evoked response audiometry. Got it? Okay. So what is the BERA? Okay, so I will tell you a story. So I tell you two scenarios. Okay, scenario number one. Okay, there is a big drug mafia. Okay, there is a big drug mafia. Okay, his name is Harold Das. Okay, so he is going to he's going to Kashmir for what to say, for smuggling the drugs. Okay, so if we catch hold of Harold Das and we measure how much drug Harold Das is having, it is called measuring the amplitude of Harold Das, how much drug he is having. Number two, we are sending a police officer called Napoleon for giving the information regarding the drug convicts. Okay, if this Napoleon police is coming back immediately, it means that he has given the information correctly to the one in the Kashmir. If he is not coming back correctly now, there could be some problem for that police. That is lapse in latency. Okay, so if there is decrease in amplitude or decrease in latency, it is pathological. I will tell you again, we are just measuring the amplitude of that wave. That is, the wave pattern is good enough or bad. If it is good enough now, the signal is good. Second one, we are sending some sound signal and we are measuring with the electrode. If the sound signal correctly gives the electrical response within the speculated time. For example, from wave 1 to wave 3, it should take only 0.5 millisecond. If it takes beyond 0.5 millisecond, it is called as increased in latency. That means that there could be some pathology like vestibular schwannoma. Okay, so these two are the important parameters that you will be measuring in BERA, brainstem evoked response audiometry. It is the gold standard test. It is a gold standard test for diagnosing congenital deafness. Then to differentiate between cochlear and retrocochlear deafness. Okay, fine. So these are the two important uses for BERA. Next one, very important diagnosis test. See, compliance is nothing but whether the ear is allowing the sound or not allowing the sound. If the ear is having air molecule, it will allow the sound very much effectively. If the ear is having water molecule, it will not allow the sound to pass further. If it is having solid now, the conduction will be reduced. So based on that, if the middle ear is filled with more air, the compliance increases. It is seen in auricular dispermity. I'll tell again, if the middle ear is filled with more air like auricular dispermity, it is called AD type of flow. If the middle ear is filled with solid molecule, for example, food plate of stapes is having a otosclerosis disease. If the food plate is filled with a solid called sclerotic bone, the compliance decreases. So the reduction of the compliance in otosclerosis is called as AS type of curve. The curve number 3 is if the patient is having a chronic negative middle ear pressure due to eustachian tube dysfunction. So this is zero pressure. For all these, the pressure is zero. If the pressure becomes negative, it is called type C curve seen in eustachian tube dysfunction. So type C curve seen in eustachian tube dysfunction. Then, if the middle ear is completely filled with water like SOM, I have showed you the image and all. The middle ear filled with the air bubbles and water, it is called SOM or serous otitis media or secondary otitis media or otitis media with effusion. All these are one other the same. So SOM, there will be a flat curve because entire middle ear is filled with only water. So the flat curve is seen in SOM or serous otitis media. Okay, I hope you have understood. Okay, let's proceed with the next one. So we have completed one important chapter, approach to ear discharge. So 2 chapters will be finishing here. We are going to finish as early as possible. So if the patient is having ear discharge, it means that the patient is having CSOM, that is TM perforation. Okay, good. The patient is not having any ear discharge. The patient is having only hard of hearing. What could be the causes? I am dividing it into 2. Intact tympanic membrane, conductive loss on audiogram. That is approach number 1. Approach number 2 is intact tympanic membrane, sensory loss on audiogram. I have already taught you how to differentiate between conductive loss on audiogram and sensory loss on audiogram and also mixed loss on audiogram. First, we are starting with conductive loss on audiogram. What are the diseases that could cause conductive loss with intact tympanic membrane? Number 1 is if there is a pinna defect like microtia or anosia. It could cause structural anomalies and it could cause conductive hearing loss. Number 2, external auditory canal stenosis or atresia. External auditory canal stenosis or atresia. Okay. Next one, congenital cholesteatoma. See, there is a disease called congenital cholesteatoma where it is not presented by the patient. It is an incidental finding. There will be a intact tympanic membrane and there will be white pearly mass behind the intact tympanic membrane. That is the criteria for congenital cholesteatoma. The criteria name is Levinson criteria. If such is the case, you should be confirming the cholesteatoma of the CT temporal bone. You should be confirming the cholesteatoma with CT temporal bone. Okay. So once you confirm the patient with CT temporal bone, you should plan for surgery such as canal wall down mastectomy or modified radical mastectomy. Again, I will tell you, if you hold the posterior canal wall, it is canal wall up mastectomy. If you sacrifice the posterior canal wall, it is called canal wall down mastectomy. So safe type canal wall up mastectomy, unsafe type canal wall down mastectomy. So if it is safe, we could give disease clearance as well as hearing reconstruction for the patient. If it is unsafe type of CSOM, you should give only disease clearance, no scope for hearing reconstruction. Always keep this in mind, very, very important. Okay, fine. Now, otosclerosis. The patient will be having carotid notch positive in audiogram and AS type of curve. So AS type of curve in impedance audiometry, the patient is confirmed of otosclerosis. I have told you otosclerosis affects commonly females, bilateral conductive hearing loss, AS type of curve, carotid notch positive, carotid notch positive, carotid notch positive. The treatment for this patient is you could start giving sodium chloride. If it is not effective, give stepidotomy. Okay, it's a surgical procedure to replace the affected stapes foot plate. Now, we are having a second disease approach, intact tympanic membrane with sensory neural hearing loss on audiogram. Okay, intact TM with sensory neural hearing loss on audiogram. What is the condition? The first one, the patient can have some syndromic anomalies. Okay, such as Waardenburg syndrome, Penrod syndrome. If there is a congenital syndrome that is affecting the child with sensor loss, we could first rule out it. Second one, if the patient is having a maternal infection like as cytomegalovirus, okay, very, very important. So torch, let's say you don't know, torch complex, toxoplasma, rubella, cytomegalovirus, herpes. Similarly, you have to see torch complex. If the mother is having torch complex positive of any of the disease, okay, that disease affecting the fetus can result in sensory neural hearing loss. So a child coming to you with these many things now, you should first rule out these things, okay. Second, recruitment phenomenon positive, Meniere's disease, the patient will be having tinnitus, vertigo, TVS, tinnitus, vertigo, sensory hearing loss, okay. You should do electrocoagulography and you should plan for endolymphatic sac decompression surgery. I repeat it, the patient is having a cochlear deafness with sensory loss, okay, with recruitment positive. I tell you again, the recruitment positive is nothing but sudden abnormal growth of loudness is called as recruitment phenomenon. The patient lower sound doesn't hear well, higher sound the patient hears a lot better. That is sudden abnormal growth of loudness is called as recruitment phenomenon positive in Meniere's disease. The patient should undergo electrocoagulography. What is the ratio of SP by AP in electrocoagulography? Can someone say the ratio of SP by AP in Meniere's disease? I want you people to answer. Please answer. SP by AP ratio in Meniere's disease. Come on, please answer. Very important. SP by AP ratio in Meniere's disease. I have already taught you. I want you people to answer. This ARM on tickets and this thing I told you no. Can someone please answer? AP by AP, SP by AP ratio is? Hello. Dr. Sandhya, Dr. Tamil, Dr. Nandini, Dr. Jennifer, Dr. Jeevan, Dr. Jaiprakash, Dr. Gaurav. What is the SP by AP ratio? Please answer, please. Yes, your doctor, correct. Dr. Thumbnation, it is more than 30. Okay, if you're not answering, it will not be interactive session. It is a monotonic lecture. Okay, so for answering then and there now, you are right on the track for understanding these concepts and you are getting it. Okay. Next one, the patient is having sensory loss, intratympanic membrane, recruitment phenomenon is also positive. Then the patient is having a high frequency hearing loss and old age, it is called presbyacusis or age related hearing loss. Presbyacusis or age related hearing loss. For such patient, you should evaluate and you should prescribe hearing aid. Clear? Next condition, intertympanic membrane, sensory loss on audiogram. The patient is having history of noise exposure in his workplace, occupational exposure. The patient should have notch on audiogram at 4000 Hz. The difference between Karach notch and this notch is 2000 Hz, only bone conduction, Karach notch, photosclerosis. This 4000 Hz, both bone conduction and air conduction. It is noise induced hearing loss. You ask the patient to change the job. Okay, because if the patient is not changing the job, the hearing loss can worsen in the coming years. Okay, that is the noise induced hearing loss. All right. So, if I'm having a sensory neural hearing loss patient, what are all the things I could prescribe for the patient? First, I could prescribe a conventional intact canal hearing aid. See, this is a earbuds piece. I am fitting over the ear canal. This is the behind the ear type. This is having a microphone, amplifier, and speaker. Okay, microphone, amplifier, and speaker. So this is the patient is having a normal ear canal, and the patient is being given with a prosthesis which fits into the ear canal. The second one is the patient is having affected ear canal, like such as I have told you already, microtia, anasia, or the patient is having recurrent CSOM, but still the patient needs some hearing aid support. That is good enough now. Baha. This is Baha. Okay. Bone anchored hearing aid is called as Baha. Okay. Bone anchored hearing aid is called as Baha. So these are the conventional hearing aids. These are just acting as microphone. They are just amplifying the sound. Okay. They are just amplifying the sound. Okay. Whereas they are having implants, middle ear implant, cochlear implant, brain implant. Three types of implants are there: middle ear implant, cochlear implant, brainstem implant. If we are implanting the material for ossicles, it is called as middle ear implant. If you are implanting the material into the ossicle, it is called as middle ear implant. Okay, if you are implanting the material into the scala tympani, okay, so scala tympani. So this inner ear is given to scala vestibuli, scala media, scala tympani. The scala tympani is adjacent to the round window. Okay, we are having two windows now. Oval window is holding the footprint of stapes. The round window is just below the oval window, so it will be forming a layer over the scala tympani, so breaching that layer. And also another important point you should notice, how we are going to insert the cochlear implant by approach called facial recess approach. Okay, so I'll show you a video how they are doing it. The facial recess approach. So this patient has been
hearing
planned
device
for
to
cochlear
restore
implant.
hearing to patients who have severe to profound hearing loss.
So
The procedure begins by performing a mastoidectomy
once we put the
accomplished by
post-auricular
removing
incision,
the
I'm
hollow
exposing
bone
the foot, they are
behind the
exposing
ear.
the mastoid part of the temporal bone. Once they are
After
exposing
making an
it, they
incision
started to
and
drill.
retracting the ear forward to expose the
This is the
mastoid
drill
bone
over
surface,
the McEwen's
the
triangle.
honeycomb partitions of the mastoid
I'm identifying
tympani
the
nerve,
nerves
which
which is coronary
supplies
nerve.
sense of taste to the facial, which is responsible
nerve.
for facial movements.
And short process of incus. So between all these structures, I'm having a recess called facial recess. Okay.
The round
so
window
through this
is
facial
where
recess,
the
I could
implant
see the
will
round
be
window. Can you
inserted.
see? Through the round window, I could insert the electrodes into the scala tympani.
Once the round window is exposed,
ultimate
a
goal
well
is
along with a
implantation of the
channel are then
electrodes
drilled
into
into the
the scala
skull
tympani.
upon
Now,
which the implant is
they will
seated.
fit the implant and insert the electrodes into the. See, can you see how beautifully they're inserting?
The electrode array
They're
is then
inserting the
inserted into the
electrodes
round
into
window and gently threaded into the cochlea.
Okay, this is cochlear implant. Fine. So the third one is cochlear implants. Very important. They may ask any of these. How it is inserted through facial recess. Through facial recess, they are reaching the round window. Through round window, they are reaching the scala tympani. Very, very important. So brainstem implant. The patient is not at all having inner ear. There is too many problems over the inner ear. So we are bypassing the inner ear and we are implanting the electrode into the brainstem. So we are implanting directly into the brainstem. Is called brainstem implant. Okay, it's not an easy surgery. Very tough surgery. It's hardly done in India. It's on the developmental phase. Okay, see here from the external unit is traveling into the skull base. This is called brainstem implant. This is called brainstem implant. Fine. Next topic. So we have done approach to hard of hearing. Okay, approach to ear pain. This question they asked last FMGE. I'll tell you. The pinna is supplied by three nerves: greater auricular nerve, lesser occipital nerve, ulnar branch of vagus nerve, and also auriculotemporal nerve to a certain extent. This external auricular nerve is supplied by auriculotemporal nerve and ulnar branch of vagus. This middle ear is supplied by glossopharyngeal nerve. Though mainly, these two nerves are C2, C3, cervical branches sensory supply. The ulnar branch of vagus, 10th nerve, auriculotemporal nerve, 5th nerve, glossopharyngeal nerve, 9th nerve. So, three important cranial nerves from the neck and face region is also supplying the ear. So if there is a problem over the face or the neck, these problems could be exerted as a referred ear pain. Okay. So problems over these nerve supplies can be exerted as okay. So this question was asked last year. A 50 years male present with complaints of swelling below the ears and pain over the lobule of ear. He was not able to close his eyes completely. He is also having difficulty eating food. Which of the following is most likely to be damaged? See, pain over lobule. He is having difficulty in eating food. So eating food now, what is the problem? Please answer. Is anything relevant to what we studied right now? Please answer. I want you to answer. This is the latest FMG question you would have gone through. Okay, please answer. Okay. Any other answers? I want answers from all of you. Then only I could discuss. Please answer. Though it is wrong, though you don't know, you just please answer. Please answer. Hello, everyone. Please answer. Dr. Dilesh, Dr. Jayaprakash, Dr. Jeevan, Dr. Nandini, Dr. Jennifer, Sandhya. Yes, Dr. Jayaprakash. Others, please answer. Pa. So only if you answer, you will get benefit from the session, or else it will be a one-way session. I don't want that to happen. Others, I need at least one answer. Others, please answer. I will not proceed without your answers. Hello. Please answer. Hello. I got only 3 answers. Yes. Okay. So based on the pain over the lobule of the ear, Dr. Gaurav has suggested that it could be a auriculotemporal nerve. Okay. Point number 1, auriculotemporal nerve could not be the answer because it will supply only the upper half of pinna. Point number 1. Greater auricular nerve supplies the lower half. It could be the answer, but the problem is the patient was not able to close his eyes completely. It means that patient nerve has been damaged. You may ask me whether there will be a pain over the lobule. It could be pain over the lobule. This is actually a case of Ramsay-Hunt syndrome. Patient is having pain over the lobules, vesicles over the lobules. Okay. This is a case of Ramsay-Hunt syndrome where you could get facial palsy, vesicles over the pinna, severe ear pain. It is facial nerve involvement. Okay, Ramsay-Hunt syndrome, it's a facial nerve palsy. They have not mentioned it as Ramsay-Hunt syndrome. It has indirect history part. Okay. Now, what are the other external ear causes of ear pain? First one, perichondritis. The perichondrium is having a feeble blood supply. So it is more prone for infection and necrosis. So you should be immediately doing incision and drainage. Okay, fine. Or else, if there is a recurrent trauma over the pinna, it could cause boxer's ear or cauliflower's ear. This is called boxer's ear or cauliflower's ear. You should be doing IND, incision and drainage, for this patient also. Okay, it could be a picture-based MCQ. Clear? Fine. Next important one, a patient is having a diffuse edema over the external canal and severe pain and tragal sign positive. It is telephonist ear or swimmer's ear or diffuse otitis externa. All are same. A very important disease. Tragal sign positive, diffuse otitis externa. You should give antibiotics for treatment of this patient. If the infection is very localized, okay, only a particular part has been affected, not the entire part is affected. Okay, infection of the hair follicles caused by Staphylococcus aureus is called as furunculosis. It is called as furunculosis. Got it? So, other important diseases that could cause pain and other important reactions in the external canal. First one is otomycosis. Can you look at the colonies? It is cotton wool appearance. The colonies are cotton wool appearance. So most common colony to get affected is Aspergillus niger. This is the black in color. The second common is Candida. The third common is Aspergillus fumigatus. Okay. The cause for this particular disease is tropical climate and usage of antibiotics. If you prolongedly used antibiotics without doctor's prescription, over-the-counter medication from a medical shop, it could cause otomycosis infection. So this is the appearance, bit tissue paper appearance or newspaper appearance or cartoon appearance, all are same. The patient will be having edematous hair canal with typical appearance. The treatment is, it could be salicylic acid or antifungals. It could be salicylic acid or antifungals. So antifungals, clotrimazole or fluconazole can be prescribed based on the necessity. All right. Keratosis occurrence. If the patient is having a deficiency of a substance called keratin attachment destroying substance, there will be recurrent accumulation of keratin over the ear canal that leads to widening of the ear canal and sometimes even leads to facial nerve palsy. It's a very pathetic disease. Only dust, which is a wax or keratin. The accumulation of keratin alone can cause a facial nerve palsy kind of disease that is called keratosis occurrence. So how are we going to treat it? Keratinolytics and surgical removal. Keratosis occurrence is an important disease. We are going to remove it with keratinolytics and surgical removal. All right. Yes. So another important disease, very important. They have asked a lot of times. They may ask this time also. Malignant otitis externa. As the name goes, it is not malignant at all. It's a misnomer. The patient will be very dreadful, very severely affected. That's why it is called as malignant. Okay. So in immunocompromised patient with Pseudomonas infection, if there is black granulation along the floor of the external canal, then technetium 99 is positive, which is a diagnostic scan, or gallium 67 scan positive, which is a prognostic scan. These are all indirectly indicative of malignant otitis externa. So important thing is Pseudomonas infection, diabetes. Pseudomonas infection, black granulation, diabetes is malignant. So can cause facial palsy in 100 cases. How are we going to treat it? We're going to remove the granulation and you're going to give antibiotics, high grade antibiotics, pointing towards Pseudomonas. Okay. Fine. So that completes the approach to